Of research. I'll just really give a brief introduction because Anabelle's been managing this project. She was in Sierra Leone for 5 or 6?
4 months and a bit.
4 months and a bit.
Yeah.
So she has all the detail and she'll be really presenting, really running this presentation. But just to kind of frame where this comes from, I guess we don't need to say why we all believe and we all know there's quite a bit of evidence on the importance of, or the role that media and communications can play in improving health. Even in places where there's good health systems, we know media can still play a role, influencing social norms, attitudes. But even more so in a context like Sierra Leone, where the health systems, are lacking a lot of infrastructure, health workers, and especially after the Ebola crisis, where the number of health workers has actually reduced. There was a need, we found, to have up-to-date information on media access figures, communication figures, but also understanding how communication could support people, considering the reduced numbers of health workers and the weak health system. So we had some funding from the Paul Allen Foundation to do this research. We have new up-to-date information on media access that will soon go on a data portal for everyone to access. So that's quite exciting because I think the last figures were from 10 years ago.
Yeah.
So we are very excited about that and very pleased that this will be available to everyone online. And this is really the main kind of introduction. I'll really leave it to Anabelle to talk about what we found.
Yeah, great. So I think I already mentioned it a little bit, but this is very out of focus, but it doesn't matter. So what we did basically is we had several focal points. One was we really wanted to have up-to-date information on the media landscape, and particularly also looking at mobile, because they're just from kind of anecdotal evidence from being in the country, etc. We knew loads of people had mobile phones, but no idea about how they're being used, what's happening with them. And the other focus was really community health, and specifically maternal, neonatal, and child health. So what we did is we had one nationally representative survey that collected data in all the districts of Sierra Leone. We surveyed 2,500 people. And then we had qualitative studies in 3 of the districts, so here Canama, Port Loco, and that's Western area where you have the capital as well, in 4 different communities. And those were very much focused on maternal and child health. Whereas the national representative survey was also more looking at media data, and we basically used both studies to gain more of an understanding of the role of communications in community health. Because the topics are overlapping but a bit different, there are actually 2 publications coming out. So today I'll talk more about the community health one, but there's one coming out probably next week. Online, which is very much just focused on the media sector within Sierra Leone. So if anyone's interested in that, we'll probably send out some.
We'll share it on the network as well.
Yeah. So I'll just quickly walk you through what we found in terms of the media sector before going into community health specifically. So what Sierra Leone, so we really focused on on the adult population, so 15 plus. And so 65% of Sierra Leoneans live in rural areas and 35% in urban areas. And what we see in terms of their media access is that mobile has appeared almost out of nowhere, right? 10 years before it wasn't there, suddenly we know 83% of people in Sierra Leone have access to a mobile phone. And what you can see here, so the green kind of speaks for rural and the blue for urban, and you see that the proportion is almost the same, right? Mm-hmm. So that basically rural people also have really good access to mobile phones, which was a very interesting finding. With radio has been traditionally the dominant media in Sierra Leone, and it still very much is. So 81% of people in Sierra Leone have access to radio, and again you see that it's quite well represented in rural areas as well. And access gets worse as we go down, so only 45% have access to TV or TV content as well, because lots of people in Sierra Leone actually watch TV on DVDs, so not necessarily live TV, but we count it as. And then 16% have access to internet, mostly via mobile phones, again, very interestingly, and only 13% have access to newspapers. Literacy rates are historically very low in Sierra Leone, especially amongst the older population. And we also looked at ownership, so really more than half the adult population owns a mobile phone, doesn't only have access to it. So access would also mean, for example, my brother or someone within my household has a mobile phone and I'm able to access it. And as you can see, radio is still very much dominant, so 69% of people own a radio. Because there has been so much interest in like, oh my god, mobile phones, like internet, new potential, I want to just quickly go through a few more figures on the mobile phone market. So what we found is most users still have very basic mobile phones. Yeah, the market in Sierra Leone is still very basic. So 52% of the phones that are owned, like you can only call and text with them. Like there's no internet browser on there, no apps, nothing at all. And only 23% of mobile phone owners have a mobile phone that has the capability to use apps. Those that you find in the middle here, they're the kind of like hybrid phones that you would find in the early 2000s. You know, they have like an internet explorer on there or something along those lines, but they're not really functional. It takes ages to load a page. You probably don't use that. And that we see also here with usage data. So 99% of people use their phone for calling. Yeah, not a big surprise. But only 31% use it for texting, and again that has to do with the very low literacy rates. Also, there are, if I get that right, I think 14 languages in Sierra Leone, and only for English there is a written script. So all the other ones, like some people write in Creole, which is like kind of the lingua franca in Sierra Leone, but there are no rules as to how to write it. So some people also don't like writing it because of that, even though they might be literate. And only 13% of people use their mobile phones for any sort of social messaging service. So that might be WhatsApp or Facebook. That said, so our takeaway is the mobile phone market is still very basic. You will most probably reach people via calls and like by using very basic phones. And then similar with the internet, like the internet is still a very urban phenomenon and like more amongst the rich. So you can see here like, so people who can afford durables, that's like I'm able to, for example, buy an electric fan or like a fridge or something. Like they're quite likely to have access to internet and apps and social media. But anyone who's below that category is very unlikely to have internet access. So if you want to reach someone who's below that income category, you're not well placed using internet at the moment still. But it's a very young phenomenon, so we think there's potential for growth. So if you look at 15 to 30-year-olds, 20% of them have access, compared to only 8% of those aged 35 plus. Okay, so that's that, like just to set the tone a bit. I want to look in more detail what we really found about the role of communications in community health. So, as I said already, like that's also true in the community setting. Like radios and mobile phones, like through our qualitative studies, very much came out as the media that people use and that people rely on. And the second really interesting finding was that people do have access to health information. People are exposed to health information. So 95% of our survey respondents had been exposed to some sort of health messages within the last 3 months. Of course, a lot of it was Ebola, so because it was still like the data was collected still during the Ebola time. It had died down by that point. It was November 2015, but it was still very much present. So 93% of our response had gotten exposed to some messages about Ebola, but also even to like more niche topics like pneumonia. So like about 40% of our respondents had been exposed to some sort of messages about pneumonia. So we have a population that actually has access to health information, but there's still demand for more health information, which is quite interesting. So it really ranked high amongst all the different topics that people wanted. So 86% wanted more information on health. That actually was the top topic. Like only, I think agriculture came next, especially in rural areas. And we found through our qualitative studies that people really act upon that sort of information if it allows them to address symptoms very quickly, especially at home if they don't have to travel anywhere, and it's cheap and easy to access and cheap and easy to implement. So those were the attributes that if that information helped them to do that, then they would actually act upon it. But we also found that in many instances people did not consult any formal healthcare, both nationally as well as in our case studies. So nationally, 9% of people had never ever consulted any formal healthcare. And we also found that people were quite passive receivers of information. So they might have been exposed to health messages, but although, and they might want more detailed knowledge or more knowledge in general on it, but wouldn't go out and take action to get that. So it was very passive. When we look at trust, we found that nurses and doctors are really trusted and in terms of health information. Radio did quite well too in terms of media, but actual people really completely outranked media. So it was really like 30% of people trusted nurses the most to receive health information, 24% doctors, and 20% community healthcare workers. And we really draw on a lot of like different people from their social networks to get health information, much more than formal sources. But 14% trusted the radio, so for example, for health information. And 3% had used a mobile phone before to get health information. So there is a bit of media involved, but really like it's much more like based in the social circles.
Who are some of the local sources that they consult?
So the main ones that we found in the case studies were mothers, aunties. The auntie is an interesting concept. So it's like basically any older woman who you trust in your social circle. Like she might be related to you, she might not be related to you. Like it's quite a fluid concept. Then sisters, husbands, friends, and traditional birth assistants.
Right.
But all of that, like this is more mainly relating to maternal and child health, not necessarily other issues so much. We also had data on like for what things people used health services, and 73% had used health services for issues related to typhoid and malaria. And that was also very much confirmed by our case study. So people would use health services if they faced something that they found really was life-threatening or involved high fever or symptoms that had to do with typhoid and malaria. Whereas like other issues weren't that much followed up. Which actually gets me to the barriers. So we found that the seriousness of the health issue, which I just said, like really, that's really what changed people's behavior, whether they went out of their ways and sought help and sought information or not. So only really in emergencies people were more likely to act. Then previous experience, also experience of people from their social networks, just where that influenced a lot whether they would go to formal or informal providers, for example, or whether they would seek help at all. We found that in our case studies, most parents very much prioritize the health of their children, so they would be more likely to seek out information or seek out help if their child was affected rather than if they were affected. Very nice people. And then also it's quite well known actually in Sierra Leone that certain illnesses are associated with spiritual matters. So for that, people are much more likely to consult traditional healers. But interestingly, what we found in our studies is that there is no clear differentiation, right? Like for one family, you could have broken bones as one issue that you go that you only use traditional healers for, whereas for the other family, like that's a complete no-go, and you will always use formal healthcare, like if you have a broken bone. And again, it's very much based on your own experience, very much based on your social network's experience. So there's no clear line or no clear-cut rules. If it's that illness, I go to the traditional healer. Globally, right? But like within like 4 people, they do categorize illnesses. But it's very hard to make broad statements about which one is which. And then also, of course, costs were one big reason why people wouldn't go out of their ways to get information or get help. And I put in perceived here because that was quite important, where it wasn't necessarily existing costs, but there was also a huge perception that formal healthcare and any formal providers will involve costs and more costs than traditional providers, which isn't always necessarily true, but that was very much a perception. I don't want to take too much time, but I found this quote extremely interesting because I thought it really illustrated how traditional healers work in these societies and why they're so important, which also came out very much during the Ebola crisis, where they were first not involved and actually people were banned to going them, which exacerbated the transmission and rate of transmission in some areas very much. So here, like, we have a religious leader who explained about his community. So the trust between the traditional healers and the community is very high, because when you go to the traditional healer, he will tell you that this is what you have to do, and at times when he gives the medication and you follow, you will be cured. For example, there is one of our brothers who had an accident wherein one of his hands was broken. He was taken to the center, so the health center, the formal healthcare provider, but after some time he was still not getting any better. He was taken to one traditional healer who was able to administer some medication, and praise God, the man's bone was restored. So the trust between the traditional healers and the community is very high. So that really relates to my point about experience and my point about preference for traditional healers. So really, some people try formal healthcare, but it doesn't work, or it doesn't work immediately. And that often changes people's perception as well in terms of what healthcare they utilize, what information they trust, etc. But that said, sorry, I didn't mention distance. It's a classic as well, I guess. But we also found some opportunities for communications to alleviate barriers and support community health. So what we found, community healthcare workers are really well placed to reach people and provide face-to-face communication. And we did find that face-to-face communication is still really the preferred way, not very surprisingly. The issue with CHWs is that they're still quite new. I mean, there have been programs going on for the past 5 years more intensively, but compared to nurses and doctors, they don't have formal accreditation, are often drawn. Imagine your neighbor suddenly turning to be your healthcare advisor, and there isn't that same level of trust yet. But they were really, everyone that we talked to had been at least once exposed to a community healthcare worker or knew about them and had generally positive attitudes about them. Then mobile phones are used by the majority of people, so it's a really new, interesting way of reaching out. As that, not necessarily through social messaging, not necessarily through text because of literacy rates and because of the technology that is available at the moment. but definitely growing opportunity. And then we saw that CHWs like are well placed, but maybe like communication tools could help them actually to communicate better, because we found that how communications worked a lot, and that relates to the point where I said, you know, most people were exposed to information, but it wasn't in very great depth and also not in great detail. And we often found community healthcare workers who we talked to lacked the confidence to talk about it. So like they would not dare to really give concrete advice because they weren't trained enough. Most community healthcare workers on average only get 1 week of training and no refreshers. So sometimes they do, but that's kind of the
And are
average.
they volunteers in CRD?
They're volunteers, yeah. There are some who get kind of compensation or little incentives, but it varies massively. So there is a drive going on at the moment to standardize, or at least like, have more comprehensive kind of strategic approach to CHW training and oversight. And then also like the high levels of trust for nurses and doctors could be built on to maximize credibility of some communication. So what we tried is, it was based on an intervention we had in India. We gave community health workers communication tools who had a nurse and a doctor speaking, and just from like, we only had preliminary feedback, but it seemed to help build trust in the message actually.
So it works by association. So if people link them to be like the nurse and doctor, then what they're saying gets credibility.
We couldn't test that. We would
Okay.
love to test that, but that's the idea, because there's so much trust in doctors and nurses, but they're not really accessible. There are about only 900 trained health professionals at that level in the whole of Sierra Leone at the moment. So you can imagine, like, I mean, people trust them, yes, in theory, but most of them haven't even ever seen a doctor.
That's doctors and nurses in total.
Yes. So I think
And a population of how many?
7 million. Not quite. I think 6.8 million. Something like that. Yeah. There are other trained healthcare workers. They might be assistant nurses, etc. They're not counted in that. But like, I'm not really an expert with that. But like, nurses who are trained to the highest level plus doctors make up like about that number. Post Ebola. Yeah.
What about NGOs? Have they filled the gap?
No, not really. Like, most of them work with community healthcare workers, and they're outreach events, and they're stuff like community sensitization events, they call them. So like, you would have like almost like a town hall meeting, and then people would be talked to, and sometimes they work in schools as well. But it's not as if, you know, you have your GP who you can go to. That just doesn't really exist, or it exists, but it's further away, it's hard to reach, or you have a health clinic but then there's only one nurse there, so she's completely overwhelmed with her work. Also, they have problems with medicine supply, so you might go but you don't get anything, right? So you can see why people also don't want to rely too much on formal healthcare, or actually not like that convinced of it sometimes. And then just gonna quickly finish up a few more points. Yeah, so the bringing informal providers on board for us was a really important takeaway, because we saw that you have to imagine the context of the research, that when we did the research, consulting traditional healers was banned by government. It was sanctioned because of the Ebola response, because they were seen as people with symptoms of Ebola would go to traditional healers, and then because of body contact it would get transmitted even more. So there was a lockdown. But still, in that context, actually people were very much trusting of traditional healers, would use them, and they were so much embedded in their community. And also from the ACAPS and some other people had really interesting research on the role of traditional healers in the big takeaway is you have to involve them, you have to involve these informal providers. And sometimes they can also do good things, like there are, for example, unregistered drug peddlers, right? And like someone just giving you a medication that reduces fever can actually be quite useful. So they have both. They can play a positive role, I think, was the important point. And then, so yeah, radio and mobile phones we thought are really well positioned to provide health information. And aside from the Ebola campaign, also that information that comes from bottom up seems to work really well. People are more receptive of it. And then if you want to use mobile phones, voice-based messages, because of high literacy rates, are probably better positioned to reach out to people. And what we saw is like really the information that was acted upon was the one that was easy to implement for people. So like the importance of actionable information very much comes out of our research again. Okay, and I think I'm probably over time now in any case, so I'll leave it there. And then if you have any more questions, then we'll send around to presentation.
Great, that's lovely. Leave that there. Looks so nice. Thank you.
It's a beautiful show.
Yeah.